All right, looks like we have a quorum, about 70 people. Good morning and welcome to Medical Grand Rounds. The speaker today, I don't think requires any introduction. You all know Dr. Scott Feitell, one of our heart failure cardiologists, and he will be speaking today on the growing role of SGLT inhibitors, not just for endocrinologists. So go for it, Scott.
Perfect. Thanks, Dr. Phatak. Welcome, everybody. Again, I can't say we're getting used to it. This is just the way it is with Zoom calls, so I apologize. This can't be in person. And I also apologize for being in scrubs, but I emergently got pulled in to cover TEs today. So as soon as I'm done with this, I have to run to the lab. But we'll dive right in and get going here. These are my disclosures, but everything I'll be speaking of is on label, so there shouldn't be any conflicts. So our objectives for today is to understand the epidemiology and the overlap of diabetes and heart disease, and really focus in and hone in on heart failure, obviously my bread and butter. Understand some of the history. I think this is one of those lessons where a history lesson is really important to understand how we got here and why are we talking about, why is a cardiologist talking to you about an SGLT2 or a diabetic drug, and some of the baggage with treating diabetics, particularly with pre-existing conditions. We'll certainly review some of the literature. There's been a lot of exciting articles come out in the last 4 or 5 years with some of these newer agents. We'll incorporate the guidelines. They haven't been fully updated, but there have been some expert consensus and some really good statements coming out from some of the leading American College of Cardiology, and then touch a little bit about future directions of therapy. Epidemiology. So this should come as no surprise that there are many there's a pandemic going on right now, but in the background there continues to be a heart failure epidemic. And unfortunately, as our population ages, this is only expected to worsen over the next 10 to 20 years. It's roughly estimated from claims data that about 2.5% of the U.S. population suffers from heart failure. It's estimated that approximately 12% of patients over the age of 65 carry this diagnosis in all developed countries. Probably a little less in underdeveloped countries. And it's estimated also, which is really concerning, that up to 76% of cases may be actually missed, particularly as it relates to diastolic heart failure, that they may be misclassified or mislabeled, with things like COPD or morbid obesity, restrictive lung disease, or maybe just non-heart failure related diagnosis. And yet these patients may actually have some degree of heart failure. So the prevalence may be even higher and we may be underestimating it. The good news is that survival is getting a little bit better. Now, unfortunately, as you can imagine, survival curves always lag behind because we have to wait, time to accrue the data and analyze it. So the best data we have is from about 2015 now. And you can look through these slides or through these graphs, no matter how you slice and dice it, that you can see the slope of these lines. Sorry, there's a lag here on my computer. The slopes of these lines, they're not overwhelming, but they do seem to be trending a little bit better. So you can see here, estimated 1 survival has finally crept over about 80%. Historically, we used to quote less, 1 in 5 patients die after diagnosis. That's gotten a little bit better. When you go out to 5 and 10 year survival, again, these curves are going to lag because patients haven't matriculated at that point. But with 2020 coming to an end, we should start getting some more updated data. So perhaps by next year's presentation, the data up to 2020 will be included. You can see here, though, compared to patients without heart failure, just looking at all comers, the average survival in the whole population over the age of 65. And you see that heart failure, this curve mimics most cancers. The 10, 15-year survival is not that great, much higher rate of dying if you have heart failure compared to the general population seen here in purple. And again, this just shows 1, 5, and 10-year survival from a different study if you differentiate whether you've had a hospitalization or not. So if you've not been hospitalized, your survival data is much better compared to if you've ended up in the hospital with heart failure. And so, one of the controversial areas is that, CMS really looks at hospitalization as a surrogate for outcomes. And this is why there's a clear signal that ending up in the hospital with heart failure means something is different about your disease. You're not going to fare as well. And so that's why we devote so much energy and time to try to figure out how to keep people out of the hospital. Again, we don't want to sugarcoat it or put Band-Aids on the problem. We want to actually find solutions that meaningfully keep people out of the hospital because there's a clear survival benefit when you stay out of the hospital with heart failure. And this has been reproduced for 2 decades now. Every trial demonstrates this metric. So, hospitalization morbidity, though, remain alarmingly high. So 1 to 2% of all hospital admissions in the US are due to heart failure. It is the single largest diagnosis reason for admission in patients over 65. Despite all of our efforts, 30-day readmission rates remain stubbornly high. And this is not unique to just RGH or the Rochester region. Nationwide, across the board, there are always a few outliers, but across the board, nationwide, the readmission rate remains stubbornly at 20 to 25%. There's really no other disease that has that type of readmission data behind it. And 50% of patients, even if you get them beyond the 30-day stretch, 50% of patients with heart failure will be admitted within 1 year of their diagnosis. So the day you diagnose them, there's a flip of a coin whether someone's going to end up in the hospital. And then 20% of those patients are going to be readmitted again. 80% of heart failure patients end up in the hospital within every 5 years. So from the day you diagnose it, I mean, those are incredible odds. I would put my money on every time that when I diagnose a case as an outpatient or someone else or a general of healthcare, they're going to end up in the ER at some point. But what's interesting about these patients is that only about 35% of these patients, when they come back to the hospital for a readmission, actually come back with heart failure. And this suggests that there's just a high degree of comorbidities and other health issues that compound our management of these patients. And oftentimes it's things like diabetes, kidney disease, COPD. These patients don't have just isolated heart failure. They're really clinically complex patients that have other etiologies driving their admissions. Now, even though it may not be heart failure, but 50% of them are cardiovascular causes. So ischemia, chest pain, peripheral vascular disease, a lot of reasons these people end up in the hospital, and it's really frustrating and complicated, unfortunately. So I think that's a good segue. And like, well, how is a diabetes medication going to help us? Like, we know these patients are really sick. We know they end up in the hospital a lot. Why is a heart failure doctor telling you to use a diabetes drug to lower A1C? And the reason is because there's so much overlap between diabetes and heart failure. There's a lot of interest in this field, and there's a lot of interest in which we'll share about why certain evidence-based medicine may help us in this cause. So diabetes alone is a risk factor for heart failure. It increases your risk in men about 2 times, and in women there's a 5-fold increase. So if a female who's 50 years old comes into your clinic with diabetes, there's a 5-fold risk of her developing heart failure within her lifetime. It's the single biggest driver of heart failure risk in women, actually. 44% of patients that end up in the hospital with heart failure actually have diabetes as one of their comorbid conditions. So again, close to half of these patients that are hospitalized have diabetes as an underlying cause. And more importantly than that, there's zero correlation really. I say minimal, but the reality is there's a growing body of literature. Numerous trials have demonstrated that no matter how aggressively you actually treat the diabetes, no matter how low you get their A1C, it doesn't correlate with survival benefit in heart failure. And there are 2 really good trials that have looked at this. There are numerous more that I could cite, but the advanced trial looked at type diabetes control with a goal A1C of 6.5% or less. It did not reduce MACE outcomes. Now, advanced did not look specifically at heart failure. It looked at all cardiovascular outcomes, but the outcome was the same. There was no significant difference between the patients that were tightly controlled and those that weren't. And one step further, the ACCORD trial went even more aggressively. They set a target of an A1C of less than 6%. They did look at a subgroup of heart failure patients. There was actually an increased risk of MACE outcomes. So by aggressively managing sugars, patients actually fared worse in this trial. Now that's an outlier. Not all the trials have demonstrated that. However, numerous trials over the last 15 to 20 years have demonstrated that no matter what your target goal of A1C or how you manage the sugars, it doesn't predict outcomes in cardiovascular patients. And that's really important. And then you take it one step further, and certain therapies may actually worsen outcomes regardless of A1C. So there's a growing body of literature about TZDs, and we'll share some of that literature here. Perhaps insulin, again, a little bit controversial, whether it worsens outcomes in heart failure. DPP-4s, there's a little bit of literature. Sulfonylureas, again, there's waxing and waning literature. One study comes out slightly positive, one study comes out slightly negative. But overall, most of these trials that with these drugs have demonstrated that they may actually exacerbate heart failure decompensation. The best example is one of the DPP-4 staxicliptin. There was a clear, the SABRE-TIMI 53 trial showed a clear increase in hospitalizations for heart failure with the use of this drug, statistically significant. And so TZDs have a well-documented history of fluid retention, weight gain, and actually carry a contraindication in the use in class 3 and 4 heart failure patients. The way the package insert reads in most of them is that you use an extreme caution in patients with type 1 and NYHA class 1 and class 2 heart failure, to the point where in our clinical practice, we try to avoid TZDs at all costs in heart failure. And so the question is, like, how did this come about? Like, why do we know so much about this? And hopefully this will be a good segue into, like, what do we do about it? And why am I talking to you about SGLT2s? Dr. Phatak is definitely old enough, and there are many others in the audience, I'm sure, that are old enough to remember this trial. It was published by Dr. Nissen back in 2007, and it was really it was a horrible trial, to be honest. It was one of the worst quality meta-analysis ever published in the New England Journal, but it really lit a fire. And even though the findings were controversial and a lot of it was disproven, it put the FDA on notice. So when rosiglitazone was FDA approved, historically, trials were really poorly done for diabetes because the endpoints were A1Cs and sugar control. And that's pretty much all they looked at. And so there was a signal that perhaps rosiglitazone may be doing more than just managing A1C. There may be an increased risk of it. And so they actually did a meta-analysis of the trials that had been published with rosiglitazone. And the reason it was so controversial is that all the trials were done with data that was not offered by the drug company. So basically, the data was publicly accessible data. They didn't have the internal trial data from the actual PIs doing the trial. They had to use what was available basically on the web to analyze the data. And when they looked at the meta-analysis, it was statistically significant that there was a worsening outcomes of MIs in patients that were on these therapies. But the confidence intervals were huge. I mean, the confidence interval goes from 1.03 to 1.98. So it was really hard to draw a hard and fast conclusion that it was actual, rosiglitazone that was driving worsening MIs. Was there other compounding factors? But the reason this meta-analysis was so important is that Dr. Nissen is never one to shy away from editorializing in his papers. And if this paragraph is what put the FDA on notice, and I'll kind of read it word for word. So these findings raise an important question about the appropriateness of the current regulatory pathway for the development of drugs to treat diabetes. The FDA considers demonstration of a sustained reduction in blood glucose levels with an acceptable safety profile adequate for approval of anti-diabetic agents. However, he really hit home that there was more to just an A1C because of prior trials, that maybe there's other things that we should be looking for in these drugs. And the FDA took that to heart. This put the FDA on notice when the chair of cardiology at Cleveland Clinic says that what you're doing is unacceptable, people take notice of it. And that's exactly what happened. So this paper was very controversial, lots of editorials, almost every major cardiac journal had an editorial written about it and how lousy the meta-analysis was, but how it brings to light that more needs to be done to understand the pathology or the pathophysiology of how these drugs work. So the FDA created a REMS program. They required post-marketing analysis, more data to be published, and the drug was re-reviewed. Interestingly, over time, the MI signal really dissipated. These drugs probably don't cause myocardial infarction. Now, I still use them in extreme caution in patients that have had CABGs and coronary heart disease, but subsequent trial data did not demonstrate what the meta-analysis was what it actually showed. So the REMS was removed. The drug carries a black box warning, but interestingly enough, it has absolutely nothing to do with myocardial infarction. It's actually to do with heart failure. More the further analysis demonstrated that these drugs cause pulmonary edema and fluid retention.
Hey, Dr. Feitell, can you move a little bit closer to the mic?
Oh,
and when you turn to the left, your voice is getting muffled, so we're losing you in and out. So
sorry about that.
That'd be good.
So the REMS was removed. We don't worry as much about black box or myocardial infarctions, but we do worry about heart failure. And a lot of this came about indirectly from that meta-analysis that was done. But the FDA went back to the drawing board. So in 2008, the meta-analysis was published in 2007. They could not ignore an editorial from Steve Nissen. And so what they did was they came back with a new evaluation for cardiovascular risk in understanding all of the background data of how common diabetes is in cardiovascular disease and how at risk these patients are. And so they rephrased and reassessed how they were going to analyze trials. They went to industry and said, if you're going to bring a drug to us, these are the pre-specified endpoints that we expect. And so they set hard and fast rules for hazard ratios. Every trial done had to have high-risk populations with them, including older folks, patients with advanced cardiovascular disease, patients with kidney disease had to be included in the trials. They had to have at least 2 years worth of data. There could no longer be a 3-month trial just looking at a reduction in A1C. You actually had to have 2 years of data. Cardiovascular events had to be tracked, so MACE outcomes had to be part of trial design. There were optional ones that they suggested would be helpful, but weren't required, including hospitalizations for MIs based on the meta-analysis. And then the cardiovascular events had to be adjudicated in a blinded fashion, and it had to be independent of the PIs for the trial. And so the FDA mandated this in 2008 and really revolutionized the way drug trials were designed with diabetes drugs. And it's been very helpful to heart failure doctors. Now we have really cool data. Now in 2020, this has just been implemented, so there's going to be even more data because now we've learned so much from the trials that were done in the interval 10 years. Now phase 3 trials have to have at least 4,000 patient years of exposure to drug. At least 1,500 patients must have at least 1 year of exposure for the drug. At least 500 patients must be exposed to drug for greater than 2 years. And they further mandated that at least 500 patients in the trial must have stage 3 or 4 kidney disease or more. At least 600 patients have to have established cardiovascular disease. And at least 600 patients must be over the 65. And there was a strong emphasis, but yet not yet required, that adverse cardiovascular events must be part of trial design, that events must be adjudicated by an independent oversight committee. And again, these will probably go even further on the next iteration. But the FDA is really honing in on this because of what happened with predecessor drugs. And so you can see since 2008, all of the, and if you look at literature from the 1990s and 2000s, there were a lot of trials that had 600 patients for 3 months and what was the A1C and things like that. Now, like heart failure and kidney trials where you have 10, 15,000 patients enrolled, and sizable percentage of these populations have real cardiovascular risk. And some of these trials, which we'll harp on, actually are dedicated just to cardiovascular patients. So the Declare TIMI 58 trial, the DAPA-HF trial, these were isolated cardiovascular trials almost independent of the diabetes. So we're starting to learn a lot about how diabetes drugs work in cardiovascular patients. And this was really one of the groundbreaking trials published about 5 years ago, now almost 6 years ago. Empagliflozin trial looking at cardiovascular outcomes, EMPA-REG-HF. And they looked at all the patients enrolled in this trial had high cardiovascular risk features, and they used empagliflozin, which is an SGLT2 inhibitor. And so here are the survival curves from that trial. You can see here that there's clear separation of these curves, and I'll harp on slide B here. That death from cardiovascular cause, you can see that these survival curves separate very, very early on in the clinical trial, and they continue to separate out to 48 months. Over the course of 4 years, you can see there's a clear survival benefit, at least from cardiovascular cause. And even in slide C, when you look at death from any cause, the curves start to separate relatively early and continue to separate out to 48 months. And obviously that was statistically significant. Also interestingly, and this was not an intention of the trial, but what they found is that there was a clear reduction in heart failure hospitalizations. This was kind of an undetected, they didn't expect it to be this robust, but these drugs actually augment the trajectory of heart failure patients. Again, why I'm here talking to you. From the empagliflozin data, we can see that patients don't end up in the hospital nearly as much. Now, they didn't look at heart failure mortality in this trial. They only looked at hospitalizations, but there's a clear signal here that something happens in heart failure patients who take empagliflozin. And then canagliflozin did their trial. The Canvas trial came out shortly after empagliflozin, about 1.5 years later, and they looked at both renal events and type 2 diabetes and cardiovascular events. And again, what they found was the exact same signal. So when you look at hospitalizations for heart failure, you can see these curves separate out very early on and continue to separate out. Death from any cause, their survival data, while statistically significant, was not as robust as the empagliflozin data, but still interesting. And for any nephrologists in the audience, the whole other topic about the role of SGLT2s in kidney disease, but you can see progression of albuminuria and the reduction of GFR over time in these drugs was first shown with canagliflozin. Now, that's the good side. There's also some bad side. And when you look at adverse events, one of the things that came about Canvas, and the reason there was a little bit of pause when these drugs came out, is that there was a signal within Canvas that patients were ending up with a higher rate of fractures and a greater rate of amputations. This has not been reproduced in any other SGLT2 data. It was only found in the canagliflozin group or in the Canvas trial. And the question was, is this a unique to this drug? Is this a class effect, or is there something else more than meets the eye here that we're not aware of? There are lots of theories as to why this is, and one of the leading theories at this point is that canagliflozin is actually the least selective SGLT2 inhibitor out there. So there's also an SGLT2 or SGLT1 pathway in the kidney, And with SGLT1 blockage, it may lead to increased diuresis effect, increased volume depletion, and that may be a signal for an increased risk of amputations and wound healing and fractures because of severe dehydration. We don't know if that's the case or not, but that's really the only difference from canagliflozin to the other SGLT2s is that it's not as selective for the SGLT2 compared to the others. In subsequent analysis and studies of canagliflozin in particular, they haven't been able to reproduce the amputation risk. So again, the FDA guides us in the package insert. It says use with caution for patients with peripheral vascular disease. It doesn't carry a black box warning. It's not an absolute contraindication to the use of the drug. It would be a case-by-case basis. And the way I look at it is, what is the risk to the patient of dying from heart failure, of having adverse events? How bad is their PVD? How bad are their ABIs? Have they already lost toes? Something to be mindful of, but not an absolute contraindication. And again, it hasn't been reproduced in any of the other SGLT2 data, but I do want to make sure we point that out. The other major risk of these drugs is UTIs and yeast infections. Unfortunately, we'll talk a little bit about the mechanism, but there is increased glucosuria. And so that may be a substrate, particularly in obese patients, patients that have a large pannus, patients that are predisposed to UTIs or yeast infections. There is an increased uptake. Again, not a contraindication to use, something that we counsel our patients extensively on. We warn them about the risk. We assess the patient at risk. We ask them what their history of it is with mycotic infections. And if it happens once on the drug, oftentimes we'll treat and move on. But if it's a recurring theme, sometimes unfortunately you have to stop the drug. Other than that, there really weren't that many major adverse events to report beyond those ones right there. Hypoglycemia was rarely reported, and really only seen in patients that were on concomitant other therapies for diabetes. And the same with dehydration, rare, but if they're on a high dose of diuretic, you may want to cut back their diuretic a little bit, although that remains somewhat common. But again, overall, a relatively favorable risk profile. And again, this is just looking at the Canvas data a little bit further from the MACE outcomes. Again, you can see cleared separation of these survival curves, not as robust as the empagliflozin data, but still statistically significant. Certainly thought-provoking, and as we've learned more and more about these drugs subsequent to this trial was published in early 2017, it's becoming clear that there's a signal within these drugs that they improve outcomes. So why are SGLT2 such potent drugs? Why do they help heart failure patients so much? It ultimately works through the kidney. So the question is, how do you link the kidney? And we all know that kidneys and hearts are intertwined, that there's this whole phenomenon of cardiorenal syndrome. So early on in these drugs development, the thought that it was simply a diuretic effect, that because glucosuria is promoted, because there's an exchange of sodium and sugar, that perhaps these patients are diuresing a little more. There's hemodynamic data out there that suggests filling pressures decrease a little bit after you initiate these therapies. But there's more than meets the eye, because it's a very transient effect. It's very minimal. These drugs have minimal effect on blood pressure. They only lower blood pressure by about 2 to 3 millimeters of mercury, not a huge amount. So certainly there is some component to afterload reduction and vasodilatation. But it's, again, the survival benefit seems more than simply just a small hemodynamic effect early on when you take the drug. And interestingly enough, in post-hoc analysis, they looked at diuretic usage in the EMPA-REG literature, as well as some of the other trials. And there really wasn't a statistically meaningful alteration in diuretic usage. So patients still require diuretic. Now, in the real world, we have seen a little bit different, but in the trial analysis, diuretics weren't augmented that much, suggesting that patients were still volume overload and still required a dose of a loop diuretic if they were heart failure. So how does it help the heart? So they've actually looked at this with empagliflozin. This is a really cool trial. It was very small. It only included 14 pigs. But it's definitely thought-provoking. And so what they looked at is LV remodeling in non-diabetic hearts, and they looked at myocardial energetics, because the thought is that these drugs do more than just secrete glucose through the kidney. So it's really easy to produce heart failure in a pig. They actually do an angiogram. They occlude the LAD for a couple of minutes, and as long as the pig does not die during that procedure, the pig will wake up in heart failure with a reduced ejection fraction. And so they looked at these pigs. They looked at empagliflozin versus the control arm. They did not receive an SGLT2, and these were non-diabetic pigs, FYI. And they basically looked at what happened when the pigs were given empagliflozin or where they were in the control group out to 2 months. And you can see that LV end-diastolic volumes are improved in the empagliflozin. LV systolic volumes are improved. LV, end diastolic volume. So all of the metrics beyond LVEF are better in the patients that got empagliflozin compared to the patients that were on in the placebo arm. And then they looked at, they looked at all these echocardiography metrics in these pigs, and they saw a clear signal that the hearts looked healthier and happier in the pigs that were on empagliflozin compared to the pigs that were in placebo. So they took this one step further, and they actually looked at after the pigs were sacrificed, unfortunately, after 2 months, they actually looked at how the pigs were metabolizing sugars. And then we found was that the empagliflozin arm was much more able to use free fatty acids, ketone bodies, all the things that hearts like. If you harken back to physiology in your first year of med school, you learned that the heart does not like glucose as a substrate. Glucose has a lot of deleterious effects on the heart when it's being used in metabolism. However, particularly in diabetics, but even in non-diabetic patients, there's a signal that sick hearts have to use more glucose because you get more ATP out of it than you do in using ketones. However, ketones are much more efficient for the heart to metabolize. So it's a trade-off. You get more ATP out of your sugar, but you're causing a lot of more oxidative stress on the heart by using glucose. And what they found in pigs that were given empagliflozin, you see a huge separation in the, again, it's a small sample size, but there's a clear signal that hearts are much more able to use free fatty acids and ketone bodies compared to using glucose when you look at the control arm. So in this slide right here, this chart C, you can see the pigs that didn't get empagliflozin had to use a lot of sugar to maintain myocardial function. Whereas in the pigs that were getting empagliflozin, you can see their free fatty acid uptake and their ketone bodies were off the charts. And then this was a third group that had no MIs and were just normal, healthy pigs. And they looked to see how the cardiac metabolism occurred. And you can see that the empagliflozin, the ketone bodies went up exponentially, and the heart loves using ketone bodies. And again, they actually did MRIs on these pigs while they were still alive to actually discreetly, echo is not always the best measurement. So they looked at LV mass, LV end diastolic volumes, LV systolic volumes, LVEFs. They did 3D echo with strain imaging. They looked at strain patterns. And across the board here, again, in a very small sample size, to make sure that they had sick hearts, immediately pre-MI, the pig hearts were exactly the same. 1 day after the MI, the hearts were exactly the same. So all the pigs suffered massive anterior wall MIs and had really sick heart muscles, or essentially cardiogenic shock. And 2 months out, there was a clear signal here that the pigs that got empagliflozin, their hearts looked much better, much healthier hearts. They looked closer to normal compared to the hearts that were on the control group. And so one of the postulated effects of empagliflozin, and hopefully we think this is a class effect because we've been able to reproduce this data essentially across the class of drugs, is that there's a dramatic increase in free fatty acids and ketone bodies in patients that get empagliflozin, which mimics how the heart likes to metabolize and get ATP compared to a heart that is sick and is in a little bit of a shock state. So this suppression of insulin, this increase in glucagon leads to lipolysis, ketogenesis, and these ketone bodies dramatically allow the heart to work more efficiently. As an aside, there's a growing body of literature of intermittent fasting as being a very heart-healthy way to diet. Still a little bit controversial. However, I'm not a hypocrite. I myself am an intermittent faster. And one of the proposed mechanisms of this is this increase in ketone bodies is a more metabolically healthy way for your heart and some of the other organs to achieve ATP efficiency compared to sugar. And so this is just a breakdown of comparing a healthy heart to a heart failure patient, and then you apply SGLT2 inhibition, you get rid of that excess glucose, and it really forces the heart to make use of fatty acids, ketone bodies, and branched chain amino acids to supply energy. And this is the way nature kind of wants us to do, that we know that hearts work better when they work with ketone bodies compared to sugar. And so that brings us to the most recent literature, and this was just published at the end of 2019. And this was unique because it was actually the first trial that exclusively looked at non-diabetic patients. So dapagliflozin, which is, again, there's a whole host of these drugs available on the market now. Dapagliflozin, they looked at patients with heart failure with reduced ejection fraction, independent of whether they had diabetes or not. And it was a huge trial. It was over 8,000 patients that were screened. Over 4,700 that met inclusion criteria. And they were either assigned to receive dapagliflozin or placebo. And then they looked at outcomes over time. And the reason I like this trial is that there were patients that were diabetic. You could be a diabetic and get in the trial, but over half of the patients were non-diabetics. And they took a sick population. The average NT-proBNP was close to 1,500. The average EF was 30%. Most of these patients were functional class 2 and 3 patients, so patients that were at risk of hospitalization, that were struggling with symptoms. And then, unfortunately, African Americans were underrepresented. Several of the sites were in Asia, so there was a decent amount of Asian representation. Most of the patients were ischemic, about 55 to 60% of patients were ischemic, and the remainder were non-ischemic population. And here are the survival curves looking at primary outcome was all-cause mortality. Hospitalization for heart failure, that same signal that we saw in both CANVAS and EMPA-REG. Death from cardiovascular causes, and death from any cause. And all of these were statistically significant. And so with that data, we now have a signal that dapagliflozin, independent of whether you have diabetes or not, provides a survival benefit in heart failure patients, and it certainly reduces hospitalization. So it's important to point out again, I misspoke, the primary outcome was a composite endpoint of hospitalization and heart failure death. And so when you look at the breakout of these, all these were pre-specified endpoints that they looked at. They were all statistically significant again, but the primary driver was hospitalization for heart failure. And again, that's not a bad thing. It is really hard to power trials for heart failure with survival benefit at this stage. You have to do trials upwards of 5,000 or 6,000 because we are getting better at treating heart failure. But we know that hospitalization for heart failure, it's a little bit of a leap of faith, but hospitalization for heart failure is an inciting event for something bad for these patients. So it's not unreasonable to consider that as a hard endpoint nowadays in most clinical trials. And again, this is just showing the primary composite endpoint was statistically met. Death from cardiovascular cause, total number of cardiovascular deaths. And they also looked at symptom management. So patients that had KCCQ scores that changed over time. Again, it's not just about quantity of life, but also quality of life is important in trials to make sure patients feel better if we're going to give them an expensive drug. And so patients not only lived longer, but they also felt better. Again, the safety profile was very favorable. And you can see here, again, there was no statistical difference between rates of amputations or fractures. This is now looked at in all SGLT trials to make sure that the CANVAS data has not been reproduced. Volume depletion, while not statistically significant, is something we do look for in these drugs because there is a potential to promote diuretic effect. Oftentimes in clinical practice, I do reduce the dose of diuretic if the patient looks euvolemic or on the drier side. Again, we see here, again, it wasn't a primary endpoint to this trial. There was a DAPA-CKD trial that was published in 2020 looking at renal outcomes in these patients, a whole other conversation, but also a favorable one. But you can see here that there is no risk to adverse kidneys events and perhaps a signal that these drugs are kidney protective. But again, I'll let the nephrologist talk about that perhaps in future grant rounds. And so with all of this data on SGLT2s, the ACC got together in early 2021. This was published in January. And they said, let's update the consensus decision pathway for the optimization of heart failure. So this is a little bit different than from true guideline recommendations. The guidelines are not due to be updated for another year or so. But the ACC felt very strongly with this growing body of literature that SGLT2s, in addition to some other drugs, that it's important to highlight the effects of these drugs on managing patients. And so for a systolic heart failure patient, stage C means they have symptoms, so they have structural heart damage plus evidence of symptoms, so NYHA classification there. They make a strong statement that ARNI, ACE, and ARB should always be first-line therapy. And for the first time that they say ARNI, so sacubitril/valsartan, is the preferred agent with an evidence-based beta blocker, a diuretic agent as needed. So once you get the beta blocker and ACE, ARB, and preferably an ARNI on board, you should now go down into this little decision tree or this little pathway for patients. And in the old days, if you pick up a paper from 2003, all of heart failure was always stepwise progression. You would go up steps. So every time a patient got a little worse, you would do something different. And they really got rid of that step mentality or that ladder mentality and really just drew zigzag arrows. That these things are equivalent, that you should be using all of these things combined to help your patient. And so once you have them on an ACE, ARB, ARNI and a beta blocker and you've diuresed them appropriately, they should be on an aldosterone antagonist as long as their GFR and their potassium can handle it. And they actually give hard and fast numbers to consider the use of these drugs. So no more of this, oh, the creatinine's 1.6 or it bumped up by 0.1 or they had a K of 4.9, I feel hesitant. If the patients have NYHA class 2 through 4 heart failure and their creatinine is under these thresholds, there's no reason you can't add an aldosterone antagonist. And I'll show you why shortly. For patients meeting GFR criteria, so the drugs were studied for a GFR greater than 30. You should be adding an SGLT2 inhibitor at this point. For patients with persistent volume overload, once you've added these two agents, you should titrate their diuretic agent to achieve euvolemia. if patients particularly are African American and still have symptomatic heart failure and they are already on, so not in place of, but are already on an ARNI, a beta blocker, and an aldosterone antagonist, plus an SGLT2 inhibitor, hydralazine and isodil. Notice there's no mention of IMDOR. I see IMDOR used all the time. IMDOR has never been studied in heart failure. It works differently than isosulfide dinitrate. So it's important to use the combination of hydralazine and isodil. And then, as somewhat controversial because there's no survival data behind it. But if the patient still is on all these therapies and their heart rate remains greater than 70 on maximum tolerated beta blocker, it is very reasonable to add ivabradine, which is an SA nodal slowing agent that doesn't affect blood pressure and doesn't have any negative inotropy like a beta blocker. That you can add this for symptom relief. The way I think of ivabradine is like a digoxin 2.0, if you will. And so you can see here very clearly that the ACC has come out very strongly in favor of a treatment algorithm for these patients. And upfront therapy should be an ARNI, a beta blocker, aldosterone antagonist, and an SGLT2 inhibitor. So we used to talk about triple therapy. A year ago, if I had given this talk, I would have talked about triple therapy, ARNI, beta blocker, and aldosterone antagonist. And really now the lingo is quadruple therapy, that patients belong on all 4 of these therapies to reduce morbidity and mortality in heart failure. And again, this is where they give the indications for use here. And so the indication for use now per the guidelines is essentially an EF of less than 40%, regardless of their diabetic status, class 2 through 4 heart failure symptoms, and in conjunction with, not exclusive of or after already adding therapy, but in conjunction with background guideline-directed medical therapy. So these really should be frontline therapy usage for patients that have class 2 through 4 heart failure and a reduced ejection fraction. Pretty bold statement from the ACC. And so now there's all these editorials, and these were just 2 of the more prominent ones that were published within the last couple of months. Quadruple therapy is the new standard of care for heart failure. And you can go ahead and go into PubMed and just type in quadruple therapy in heart failure. You'll get all kinds of editorials written by really prominent physicians that advocate that the survival benefit is there. And just to survive, this is one of my favorite slides, courtesy of Dr. Fonero, who I wish I knew better, but is a wickedly smart guy. And so he put together this great slide, and he shows it in every talk, and he allowed me to share. The cumulative impact of evidence-based heart failure therapies reduced EF. So any patient with a low EF that's symptomatic, these are the relative risk and the 2-year mortality benefits with all of our standard of care therapy. So ACE or ARBs, you'll get a 23% relative risk reduction and a 27% reduction in mortality. You add a beta blocker to that, 18% 2-year mortality improvement. Aldosterone antagonist on top of that, 13%. You switch your ACE or ARB to an ARNI. So this is on top of this already amazing survival benefit. Now you switch it out for sacubitril/valsartan. You have an additional 10% reduction in mortality. And now you throw an SGLT2 inhibitor into the mix and you get a 9% reduction in mortality. So the cumulative risk reduction of all evidence-based therapies for heart failure gives you a relative risk reduction of 74%, an absolute risk reduction of 25%. That's insane. A number needed to treat of 4. I mean, we look at trials, in many other facets, even in heart failure, where number needed to treat of 25, 30, 40, we get very excited. But just by putting patients on 4 simple therapies, that's it, 4 drugs that are easy to take, have minimal side effects, are very well tolerated, and you get a number treated of 4. It is a huge disservice to not put patients on these therapies. And it is very frustrating when I continue to find that patients aren't on maximally tolerated guideline-directed therapy. And nationwide, this is not unique to RGH or Rochester. Again, this is nationwide. Less than 1% of heart failure patients are on maximum tolerated guideline-directed therapy. The ACC and the AHA have looked at this extensively through their Get With The Guidelines program, and less than 1% of patients are on maximum tolerated guideline-directed therapy. It's a huge disservice to these patients. Future directions. So I'll plug our own program here. So this is a trial we're part of. So dapagliflozin and the effects cardiovascular events in acute heart failure. So all of the trials that have been done today have been in stable outpatient settings, or patients get enrolled at the time of discharge. So we're actually part of the DAPA ACT TIMI 68 trial, which is looking at acutely decompensated patients that are in the hospital to see what the effects of starting these drugs very early on in disease courses. So patients within 24 hours of arrival to the ER are allowed to be screened. Up to a week in the hospital, they can still be screened. And we're looking to see if dapagliflozin can even have a greater effect early on in disease course rather than waiting either a couple of days, a couple of weeks, a couple of months for initiating therapy. So more to come on that. HFpEF is always a hot topic. I invariably always get a question, well, can this drug be used in HFpEF? So I'll try to hit it off. We don't know. There's no HFpEF data yet. You know, certainly patients that have diabetes and you're using as a diabetic drug, there's no reason not to. But to actually look at outcomes in a HFpEF patient, we don't know. So hopefully the liver trial should wrap up completion sometime later this year. COVID has obviously delayed enrollment, but by the end of this year, early next year, we should have data on HFpEF finally. And then looking at type 1 diabetics, another controversial area. Because of the way this drug works, in theory, again, very theoretical, it may have a role in type 1s. There have been type 1 trials done, and the problem is the increased risk of DKA. However, those trials were not done in heart failure patients. And so the question is, does the survival benefit in heart failure in a type 1 diabetic outweigh the potential risk of DKA? We just don't know that, but we're hopeful to have data on it pretty soon. Again, COVID has slowed down enrollment in these trials, but we should go soon. I was ambitious, and I thought I was going to talk about GLP-1s as well. However, as I was doing this talk, and I already had 45 slides on SGLT2s, I thought better of delving into GLP-1s, but I thought that would be an awesome way to plug myself and say, if you want to learn about GLP-1s, invite me back for another grand rounds, and that's a whole nother topic, which also interests me greatly. And I think with that, I will finally plug our membership in the Cardiometabolic Center Alliance. Obviously, I have a great deal of interest in this disease, the overlap between diabetes, kidney disease, and heart failure. So many of our patients suffer from that trifecta. The folks at St. Luke's Mid-America have been at the leaders. Dr. Kosi Morad, who's going to be giving a cardiology grand rounds here in a couple of weeks. He's one of the lead authors in almost every trial I cited there. So he is really a godfather and a leader in the overlap between diabetes and heart failure and kidney disease. So he runs the largest cardiometabolic center in the country. And he said, well, why can't we share what we've learned and help grow these programs in other centers? And luckily, because of what we've done in this space and our relationship, we became charter members of this alliance. We're one of the first 5 centers in the country to have this accreditation. And so we will happily take on any of these sick, complex patients with heart disease, diabetes, kidney disease, really trying to use guideline-directed medical therapy, standard of care approach, really standardize and make sure these patients are on the right therapies to improve outcomes and improve survival. So feel free to refer challenging patients to us. We're happy to see them. And with that, I will shut up and happily take some questions if there are any.
Great, thank you. Yeah, there are a couple of questions that showed up on the Q&A. So Dr. Carrie Graff asks, what is the number needed to treat with dapagliflozin for non-diabetics to prevent one death, and over what period of time?
So interestingly enough, so in the non-diabetics, the data was even better. Let me go back here and see if I can see that slide. So I don't remember the number needed to treat off the top of my head, but it was right on par with this data. So you're talking a number needed to treat about, I want to say it was around 20. Don't hold me that exact. DAPA-HF is an open access journal. You can just Google it. It's in the New England Journal. It'll be in there. But I want to say the number needed to treat was about 20 to 25 in the non-diabetic arm. But please don't hold me to that. I'd have to go back to those.
All right. And then the second question, I think you answered already. Dr. Jackson asks, do these work for heart failure with preserved ejection fraction? And the answer is
we don't know. There's certainly I mean, obviously every drug that gets approved for HFrEF, everybody jumps on the bandwagon and says, oh, maybe there's a role for HFpEF because we have so little. We just don't know. I suspect by the end of this year, some of the data will be published. It may get pushed into 2022, depending on wrapping up enrollment. But we will have data very shortly, but no one knows.
Yeah. So another question here, if the patient is on an SGLT2 inhibitor, but his chronic kidney disease is worsening, GFR drops to less than 30, stop or continue?
Right, so the mechanism of action of these drugs, so as the reason that GFR of 30 is in there is quite honestly, as a diabetic drug, these drugs are useless. Notice this whole talk, I didn't mention A1Cs once, right? Because A1Cs actually don't matter, particularly in the heart failure space. But in terms of most cardiovascular outcomes for diabetes, as we alluded to. So if you're using it as a diabetic drug and the GFR starts to drift down, you're not going to get any A1C bang. You're not going to lower the A1C at all. These drugs need GFR to be able to filter, to be able to promote glucosuria. So you need those little channels in the proximal tubule to be able to exchange and get rid of glucose. So as your kidney starts to die off and your GFR drops, you don't have enough of them, and you're not going to get any lowering A1C. Now, whether these drugs have a proposed mechanism as the GFR drifts below 30 is somewhat controversial. I'll delve into the off-label part of it. I mean, off-label, you can certainly use the drug with a GFR less than 30 if you're using it for heart failure survival. However, it remains unstudied. I believe in the empagliflozin trial, the GFR cutoff may have been 20, so maybe it was studied there. But around 30, all the package inserts use a GFR of 30 as to saying that the drugs don't have benefit. But we don't know that. Now, certainly in a dialysis patient, again, even more controversial, probably this drug doesn't derive much benefit unless there's some mechanism we're not aware of or we haven't really delved into that. At some point, someone will probably do a dialysis trial in a heart failure population because these patients are so sick and have so few therapies. But even ACE/ARBs, ARNIs don't have great data in dialysis patients, yet we use them. We think they provide some benefit to patients. We just don't really know. So from a diabetes perspective, I would not use this drug if the GFR goes to 30 from a non-heart failure, just plain old diabetes case. But in a heart failure patient, though controversial, it's a risk-benefit discussion. My question would be is why is the GFR getting worse? And in the setting of heart failure, it usually is the heart getting worse is driving worsening kidney function. And those are patients that need to be swanned. We need to understand their hemodynamics. We need to see if they're in cardiorenal, if they're running around with a CPP of 15 to 20. It may be renal congestion that's driving their worsening GFR. The other process is that you're probably over-diuresing them. So if they're on a diuretic and they're on an SGLT2 and you see their GFR worsening, particularly if their BUN is going up with it, there's a possibility that you may be over-diuresing, that the compensatory mechanisms for particularly, the synergy between ARNIs, SGLT2s, and aldosterone antagonists, they may not need as much diuretic. So one of the common things we see is that the patients end up too dry finally, that we finally got them on the right therapies. They simply do not need as much diuretics anymore, and you really should be cutting back their diuretics or getting rid of their thiazides or whatever else they're on. So someone with rising creatinine in the setting of a SGLT2 should not be a default stop the SGLT2. It should be a huge red flag. Why is that GFR getting worse? And is the patient clinically getting worse? Are they clinically getting better? And then I would look at volume status very closely to figure out where the disconnect is.
All right. Dr. Obaji asks, is there any role in prevention of heart failure in pre-diabetic and or obese patients who don't yet have heart failure? Yeah.
No doubt about it. And I mean, that's one of the reasons why we joined the Cardiometabolic Alliance. I mean, that's the future direction of these drugs is Dr. Kabasi is really actually a preventive cardiologist, though he plays around with the heart failure doc sometimes. So if I do, or if someone else gives a talk on GLP-1s, I think the GLP-1s are a little bit ahead of us in terms of SGLT2s, in terms of their preventative role. But there is undeniably a signal or a pathway that suggests that these drugs may be preventative. We just don't have as much data in that space. If you look at the DECLARE trial, which looked at some of the early SGLT2 data, I mean, these drugs do reduce MACE outcomes. And so some of the SGLT2s actually have in their package insert that in diabetics, to reduce MACE outcomes, you can use these drugs. They actually have that as an indication for use. So my general thought process of, and I think a growing field within cardiology, particularly preventive cardiology, is that if you're going to have to pick a diabetic agent for a patient, why would you pick a TZD that has all this black box warnings and all this controversy behind it, when you can use a newer agent such as an SGLT2 that has a very favorable MACE outcome? And that's really the way you have to think about these drugs nowadays. Is it sucks that in America, you got to look at the drug cost and the coverage gaps, in terms of patients affording these drugs. But if costs were not an issue for you, I would tell you to look at the risk profiles and the MACE benefits and really start picking drugs like GLP-1s and SGLT2s rather than using sulfonylureas and DDP4s and drugs that are a little bit more controversial, don't have the MACE outcomes behind them. Why would you do that for yourself? So I definitely think there's a role for preventative. In terms of preventing heart failure, we don't know if that's harder to do a study on. But preventing MACE outcomes, there's pretty good data that SGLT2 should be a first-line therapy for diabetics.
Yeah. So this is more of a comment than a question. Dr. Singh says, beware of euglycemic DKA in patients
really
on
good point.
SGLT2. Yeah.
Right, absolutely. So DKA is definitely a risk, no doubt. It's rare, but you'll find it, and they can have totally normal sugars and be in DKA. So it's really important to get that Chem7 and look at your bicarb, and if it's abnormal, start to worry a little bit about it. Much more commonly seen in patients that have diabetic polypharmacy, as I say. So it was found much more commonly in diabetics with that were on background insulin and sulfonylureas. But it can happen to anybody. And just like anybody that advantages diabetic drugs, DKA is going to be, again, luckily much rarer in type 2s to begin with, and then much more rare in patients, really not seen in non-diabetic patients in DAPA-HF. The non-diabetic heart failure patients, we did not find any DKA, but in your diabetic patients, as always, for any of these therapies, be mindful of a normal sugar with some DKA, particularly if they're on other background therapy. Thank you for pointing that out.
Then Dr. Jackson asks, which SGLT2 do you prefer?
I have to be careful with my what is it called? The things I released. So as I believe it is a class effect. I honestly truly believe that. I suspect in short order it will be deemed a class effect. Right now in non-diabetics, the only drug that has FDA approval for non-diabetics is dapagliflozin. And so I prefer dapagliflozin only because in terms of insurance coverage, I can cite that in the FDA has approved it for non-diabetic heart failure. I suspect in very short order, epagliflozin and canagliflozin and a couple of the other ones will have that FDA approval as well. And then it's really whichever one is cheaper, whichever one is on formulary for the insurance plan. I mean, the same way we practice all of our other medicine. I really truly believe it's a class effect. But in your non-diabetic patients, for now, I would say if a non-diabetic heart failure, the only reason I choose dapagliflozin is that I have the FDA approval backing me, so I don't have to argue with the insurance company about off-label use or anything like that. But I guarantee you, in very short order, epagliflozin and canagliflozin will probably get those inserts, those FDA approvals, and in which place it's whichever one is cheapest for the patient or whichever one you have the easiest time. It seems to be a class effect. Where if I gave this talk in 3 more months, I bet you I would make that statement very, very clearly.
Right. So, and then I'm going to make this the last question. Are patients being enrolled in your trial here? And what kind of patient? Yeah.
Right. So for the TIMI 58 trial, they have to be hospitalized. So we screen all of our patients. So we are involved in obviously many trials. So we do a pretty good job of enrollment. So if patients meet the inclusion criteria for TIMI 68, then absolutely we will enroll them. Unfortunately, that trial as of right now is only available to inpatients. On the outpatient side, through our cardiometabolic center colleague, unfortunately, COVID slowed down research for a bit here, but we hope to be involved in another SGLT2 trial as well as 2 GLP-1 trials. And I'm sure everyone will be super excited. We actually are going to have a couple HFpEF trials on board within the next 3 to 6 months here. So we plan to ramp up our presence within this state, within this area in very, very short order. Again, we were delayed by 3 months because of COVID restrictions. But by the springtime, we should have several trials up and running and that's one of the reasons we wanted to join this alliance is it will give us access to a lot of clinical trials. The other thing I'll plug the program for is all of these patients are entered into a REDCap, a national registry. So every patient that comes through the Cardiometabolic Center Alliance referral gets put into REDCap, and then as all the centers enroll, hopefully we'll be able to analyze data even more conclusively and have a lot of good retrospective data that shows us, leads the way to more trials, more randomized trials down the line when we start to see signals about how these patients are doing, and hopefully demonstrate that a team-based approach to these patients. This cardiometabolic center is done in partnership with our non-invasive cardiologists that do preventative care. We've had extensive talks with our endocrinology colleagues. Dr. Cartuccio has been very supportive of us. The diabetes educators, our bariatrics colleagues, our cardiac rehab program. So this is really a team-based approach rather than treating patients in silos. Trying to make sure as a team we're getting these patients on the latest and greatest therapies to help with weight loss, exercise tolerance, survival benefit, all of the above.
All right, great, thank you. No, this is a significant advance. People should know about it. So thank you for this. There was obviously a lot of interest. We got 154 people.
Oh wow,
signed on. So
very cool. Yeah. Again, I hope I'm invited back. I would love to have another talk on GLP-1s. I wanted to do it service. I don't think it's fair to lump the 2 of them together because they're different populations and different data, but both overwhelmingly interesting data.
Sounds good. Thank you very much. And thank you all. Have a good day. Yeah.